Okay, so this is the May 5th class for the 2020 EMT. So right now, roll call, we have Caitlin,
Here.
we've got Chuck,
Chuck is here.
next one we have Danny,
I'm here.
Daniel,
I'm here.
Jeffrey,
I'm here.
John, and Kristen.
Here.
Crystal,
I'm here.
Lisa,
I'm here.
Michael,
Here.
Mike, and Ben. Okay, and Stephen.
Steven's here.
Okay. All right, so I'm going to mute you guys.
We have, well, like right there.
Okay, so we've got Jaron, and Chris Snow said he was going to be here. He was here a second ago.
Mm-hmm.
So can everybody see the presentation right now?
Yes.
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 There.
Yes.
Okay. So I know way back when we actually were all meeting face to face, we've seen this one before. Okay, we went through abdominal and chest right before we got done. So hopefully this won't take too long. We'll kind of go over these again a little bit. Main thing with soft tissue injuries, you're going to have
I'm gonna set this over.
blunt injuries, penetrating injuries, the barotrauma, the changes in pressure, and burns. All of those can be really significant, right? So, main thing we talked about, you can pretty much die from most of these, okay? Whether it's bleeding out or from an infection, but we can usually prevent these, okay? Way back when we talked about anatomy, we said the skin is its first line of defense. It's the largest organ. For one, we protect our body with it, regulates temperature, keeps us from getting infections. Number one thing with soft tissue injuries, if it's bleeding, stop it. Once we do that, we try to reduce that infection rate and then try to make it so that things don't get worse. With that in mind, we do have different layers, different thicknesses of the skin. Old people and young people, little kids, they have real thin skin. It hasn't developed yet. At the same time, eyelids, lips, ears, scalp, soles of your feet, those are where it's thinnest. That's where you're going to have those people that get cuts and scrapes, and they're going to look like they bleed a lot. At the same time, those are real easy to take care of, right? All we got to do is probably put a little bit of pressure on them, and those injuries will stop bleeding. We talked about the two main layers, the epidermis, which is the outer layer, and then the dermis right underneath that. There's your picture for it. So you got the epidermis up here at the top, your dermis in the middle, and then that subcutaneous tissue is usually where your fatty layer is, and then your muscles underneath that. So bodily openings, we know where our bodily openings are. We don't need to really go over those. They're all lined with mucous membranes. That way there can be transmission between it. There's all our functions, like we said, protection against infection, regulates temperature, that fluid balance. We can retain water, or if we need to cool ourselves off, we start sweating, right? And it's a sensory organ, because how do we interact with stuff? We touch it. Any break in the skin, any laceration, any cut runs the risk of infection. So our 3 types of soft tissue injuries. We talked about closed. That's where your blunt trauma comes in, where let's say somebody gets hit with a baseball bat. There's no open outer injury to it, but all the damage is on the inside. So you could have internal bleeding, broken bones, you name it. Open injuries are exactly that. They're open. That's when you have your open fractures, lacerations, stab wounds, gunshot wounds, those types where it creates an extra opening in the skin that wasn't there to start with. And your burns. What's the most important thing about burns? We lose our temperature regulation. Okay, they're going to start getting infections very easily, and we need to cool them down. So the pathophysiology of closed and open injuries. Main thing, stopping the bleed, right? Next part's where it starts getting inflamed is trying to close off all those broken vessels so the tissue gets inflamed. Eventually, more cells start moving to those damaged areas to build those vessels and skin back up. And eventually you could have a scar from it. That's where that collagen comes in. So a contusion is obviously the bruise. That's that darkening underneath the skin from blunt force trauma. Hematomas are a little bit different. That's where there's a lot of blood that collects in the tissue or the body cavity. So that's where you'll see that large swelling, kind of dark purple, almost black. Kind of looks like a bubble every once in a while. See it a lot in old folks who have blood thinners and have head injuries. You'll see hematomas like that. Let's see. All right, hang on. See that Lisa sent a message that says, "Can you make me the presenter?" Is that? Do I need to do that?
I was just clicking on different buttons here on my screen, so yeah, just ignore that.
Okay, just making sure. I'm still trying to work out the kinks to go to meeting. I'm not very tech savvy with it. All right. So we talked a little bit about crush injuries before. A lot of times that's where there's some massive amount of force is on a specific body part. It could be your legs, it could be your arms, it could be the center of your chest. Main thing is it's the amount of force pushed down on it and then the length of time. The longer it sits there, the more likely you are to develop crush syndrome. Where you have a buildup of toxins in the body in that associated part. You get compartment syndrome. That's where, let's say you have an injury, a tree falls down on a dude's leg. That compartment syndrome is where the swelling starts breaking up the tissue. And the main thing with severe closed injuries is they can damage those internal organs. Okay. Problem is we can't see them. Most of us don't have x-ray vision. So even if somebody gets hit with a bat and it doesn't look that bad, we're not sure if they maybe ruptured their spleen, have a lacerated liver. We can't tell. Those folks are always the ones that we need to transport as quick as we can, and they need to be reassessed all the time. So open injuries, we have our abrasions, which are little cuts and scrapes. Lacerations, I think we all know what lacerations look like. Avulsions is where the skin's kind of peeled back. And then penetrating wounds, so your stab wounds, gunshots, rebar pushed through your leg during a car wreck, things like that. So like I said, abrasions, most of the time they're just kind of almost like carpet burns. All this affects is the top layer. Most of those don't bleed. At most, they'll just be slightly uncomfortable. Laceration is a little bit more of an issue. Most of the time, it's a sharp object. Blunt force trauma can cause the tissue to tear. Usually, that's a significant amount of force. Main thing with these are we're going to want to stop the bleeding. Okay, whether that's just direct pressure, packing the wound. Here's your avulsions. Like I said, it kind of peels up that layer. Same thing, we want to kind of stop the bleeding with that. If we can, keep the piece intact. If it's extremely damaged, we're not going to necessarily worry about it. We're more concerned with stopping the bleeding than putting the flap back together. Amputation is pretty self-explanatory. Penetrating wounds, same thing. Main thing with this is we can have more damage to stuff that we can't see, kind of like blunt force trauma. Depending on how large the object was, whether it was a knife, whether it was a projectile, other parts of the body could be affected. You know, if it was a 6-inch blade, how far in, what direction did it go, what organs can it hit? Same thing with projectiles. The entrance wound is not always going to be in line with the exit wound. You could get shot in the stomach and the exit wound could be up in the shoulder. Things like to bounce around. Is everybody able to keep up so far? Do I need to slow down?
You're good. I'm good.
Okay.
Good.
I know it's mainly a review. I
Quick.
just wanted to.
Sorry. So I was reading over the chapters before, and I noticed that we weren't like going. Well, I guess we are going in order, but like exactly what chapters are we going over tonight? Because I have like the PowerPoints pulled up on my laptop and I'm on my iPad on here.
Okay. So it should be 26, 29, 30, and 31.
Okay.
On the schedule that we sent out in the email, it should have all the chapters that we go over each class period on the.
Okay, thank you.
All right. So like I was saying, with these stabbings and shootings, a lot of times if somebody's getting stabbed or somebody's getting shot, it may not be just once. So you need to make sure you're looking for all kinds of injuries, okay? They may have multiple wounds. If you can, determining the type of gun is great. If they don't have it on scene, don't worry about it. That just helps figure out what size bullet it may have been, what kind of pressure wave it's going to create, what kind of damage is going to be done. Some blast injuries, those are your explosions. So you have your primary, secondary, and tertiary, which is just your third hit. So your first hit is obviously the initial force. Secondary is going to be your shrapnel. And then that third force is going to be whatever you hit on the way down. Space assessment, like we were saying, it's a lot harder to figure out what kind of injury somebody may have if it's a closed injury. So with that picture, we may not know exactly that they have, a ruptured spleen or a lacerated liver or a separated aorta. We don't know. That's why if we see these kinds of injuries, they always need to be transported as quickly as possible and rapidly assessed. Scene safety, main thing. If you're going out on some kind of traumatic injury or it's assault or anything like that, obviously keep yourself protected. Doesn't make sense to go out there guns blazing if you're going to get injured yourself. Once you get there, kind of do that windshield survey where you can see if any of the mechanism of injuries are there. So if you get there and you see 3 different vehicles and 2 of them are upside down, you're going to know that there's probably a significant risk of having high-level injuries. At the same time, if you're being called out for multiple GSWs, you're going to know to look for some of that. So first and foremost, treat your life threats. If you see somebody squirting blood out, obviously, we stop that first, right? So find your life threats, figure out your transport priority. Most of the time, if it's that serious, you're going to transport them immediately or as soon as possible. Once that's done, you do your general impression. It's when you kind of get your first look at them, see what their condition looks like, whether they're alert, whether they're conscious. That's when you start doing that actual patient assessment on them, seeing if they have any other injuries, seeing if they're even able to respond, what their breathing is like, anything like that. So we went over most of this before. We had written it down on the whiteboards before when we were doing patient assessment. But your ABCs, airway, breathing, circulation, high flow oxygen is always a good thing, especially if they're losing blood, because they're also going to be losing oxygen supply. Number 1, though, make sure they got that airway open. Assess their heart rate, skin condition and color. If it's pale, if they're clammy, if they have blood all over, all that stuff can kind of key you in on how serious this patient may be. And then decide on your transport decision. Like it says, most of these are considered load and go. Obviously, a poor general impression when you get there and say, oh man, this is bad. Those folks need to go quick. If they can't quite talk to you right, if they're altered, having trouble breathing, vital signs are abnormal, whether that's low blood pressure, low heart rate, extremely high heart rate, lack of a heart rate, signs of shock, and obvious pain. So it says investigate the chief complaint. Chief complaint is always what the patient is complaining about. That's their main concern. Okay. A lot of times when you ask them, okay, well, what's going on? What's bothering you? They'll usually give you what they see as the most pressing concern. And then you can start kind of taking it from there. For one, all these other problems they could have diabetes. That doesn't help with soft tissue injuries because they won't heal as well. Same thing if they have high blood pressure. High blood pressure, we may not be able to tell how bad they are. Or they could have a history of low blood pressure. So normally they say, okay, well, my blood pressure is normally 90/40. Well, now their blood pressure is 86/38. It's not that far off from what their normal is. Are they bleeding out? Are they in shock? We have to kind of keep an eye out for stuff like that. Once you get your primary assessment done, your secondary is more of a in-depth look at the patient. That's your full body look, checking your interventions, checking any of your vital signs and rechecking them. Most of the time, this is done while we're in the truck. This is the one you do every 5 minutes, every 15 minutes. Check on them. Get your vital signs. Vital signs doesn't mean just the numbers. It doesn't mean just a 16 respiration rate or a 98 pulse rate. It's also what they look like, what their skin condition is. Reassessing. Most of these patients that we're talking about, especially with these kind of injuries, we reassess every 5 minutes. Usually critical. Same time, anytime you do an intervention, if an IV is done, you reassess the patient. If you put oxygen on them, you reassess the patient. If you have to put an X collar on, reassess. So if nothing else comes from this, just remember to reassess the patient all the time. Stuff changes in an instant. Talked a little bit about communication a while back and documentation. Make sure you give them a clear picture. Give them a good description of what the mechanism injury was. Don't just say, oh, well, they had a ground level fall. Well, they slipped and fell and they hit their head on the nightstand, on the edge. It's a little bit more detailed. How much blood they've lost. Sometimes it's hard to tell, especially if they've been laying in it or moving around. You might not be able to tell. Try to learn how much a specific amount of blood is. Best way I can think of telling you to do that is fill up a 2-liter bottle of water and dump it out on the ground somewhere so you can see how much that is spilled out. That's usually when it's a significant amount. Little bruises, contusions, usually emergency care is not needed for that. But at the same time, if you have a large amount of injuries that are severe, you will most likely have hypovolemic shock because you'll be bleeding out. Same time with that reassessment, we're watching those areas of injury. We're watching to see if they're getting better or if they're continuing to bleed. So close soft tissue injuries with the Rice's mnemonic. So that's rest, ice, compression, elevation, and splinting. Most of those we're taking care of, okay? Hopefully, if they're on the stretcher, they're hopefully resting a little bit. Ice packs, ice helps reduce swelling. Compression, that's what we're doing with bandages. Anytime we have lacerations or anything like that. Elevation helps reduce the blood flow. And then splinting any injuries, be like your broken bones. There's some things to look for when you're thinking of shock. Most of the time, the first thing you're going to see is that increased heart rate, increased breathing. Okay? You start breathing fast. You start sweating. Eventually, they'll have their blood pressure start dropping. Once their blood pressure drops, then they'll start having a change in mental status. We want to try and get ahead of the curve on that. Make sure before they get into an altered mental status that we're trying to address those issues. All right. Standard precautions. That's putting on your gloves, putting on your eye protection. Now it's putting on your N95, making sure you're taken care of. If life-threatening bleeding is there, if you're the lead, direct a team member to take care of it. Have them put on direct pressure. That way you can continue your assessment and keep checking for anything else. At the same time, if you have any wounds on the chest, the upper abdomen, upper back, anything that might be associated with the lungs, you cover it with an occlusive dressing. That way, if air is escaping because they have a pop lung or anything like that, we take care of it. We can seal that chest. That way they can still breathe. That's where taping it, a bulky dressing on 3 sides and keeping one open to burp the injury comes in.
Hey, Sean.
Yes.
When you're talking about altered mental status, when you have a patient that has Alzheimer's, is that their normal? Would be altered mental status, or
one thing you can do
okay.
is if there's any, you can ask them, hey, is this their normal status?
Okay.
A lot of times it'll be harder to tell, but that's about the best answer I can give you for it. If somebody's there
Okay. All right.
and can tell you, great. If not, it's not that big a deal. Just err on the side of caution.
In my personal experience with a patient with Alzheimer's, they're going to have somebody with them at all times anyway, so there should be somebody there.
Right. Exactly. Well, and then
Right.
there's chances are you could come across one that's in the oh man, my mind just went blank. Nursing home, that place. Let's say you're in the nursing home, you got a patient there. Staff says, "Oh, they're over there. They fell." Well, a lot of times that's the end of the care information we get from them. So, if you can, if somebody's there, ask them. If not, personally err on the side of caution.
Okay. All right. Thanks, Sean.
All right, give me 1 second to get this fixed. My computer screen messed up on it. 2 seconds. I gotta go all the way back. Y'all bear with me. Okay. Life-threatening bleeding. Direct even pressure. Most of the time, direct pressure will take care of it. If not, we do have pressure dressings. Worst case scenario, use a tourniquet. Main thing is we just want the bleeding to stop. At the same time, any open wound is going to be contaminated. Blech. Okay. Whatever caused that injury probably was not clean. Just assume that they have a possible risk to infection and try to keep it as clean as possible. Same time, if you have a injury where the arm is deformed or potentially has a break, go ahead and splint it. A lot of times, if we can't see if there's a confirmed fracture, we can still control that bleeding on the inside by splinting it in the appropriate position. All right, abdominal wounds. That doesn't look pleasant at all, does it? Sometimes, especially with people having previous surgeries, they can have organs pop out or an evisceration from a trauma. Main thing when you see organs come out, you do not poke them back in. We're just going to cover those with moist dressing and get them to the hospital as fast as possible. Impaled objects, main thing, we're not going to take them out unless they are blocking the airway or causing issues with the airway. Most things that have been put into a person are going to stay there until we get to the hospital. Now, if it's in their chest and they all of a sudden go in a cardiac arrest, yes, we'll have to take it out. Can't do chest compressions if they've got a rebar right in the center, right? Neck injuries can definitely be life-threatening, not just from bleeding, but because they could have an embolism. They can suck in air. As soon as we can, we need to cover those wounds as quick as possible. Manual pressure, we're not going to tourniquet somebody's neck, no matter how much we don't like them, but give them good pressure, preferably not on both sides of the neck. Animal bites. Animals are nasty individuals. They have a bunch of bacteria, same as us. Okay. Anytime somebody gets bit, they need to get looked at. They will most likely have an infection. One thing to look at is rabies. Okay? Definitely not a fun infection. So if you ever come across somebody that has a animal bite, convince them to go to the hospital and get looked at. Same thing with humans. We're all nasty. Humans have some of the nastiest mouths in the world. We put stuff in there that's not supposed to be there. Same thing. Transport them to the hospital, get them looked at, be prepared for infection. So, dry sterile dressings, immobilize it with a splint if you need to. Transport them. Pain relief if necessary. All right, burns. Worst thing about burns, like I said, is it removes that protective layer we have. Okay. Same time, we talked about chief complaint. Most time when there is a burn involved, the patient's chief complaint is going to be that they are on fire or they are burning. Okay. They may not realize that they have 2 leg fractures. All they know is that the grill blew up on them and their chest was on fire. So make sure once we get the burns taken care of that we're also looking for anything else. Same time, children, older patients are more likely to experience shock from this. It's a lot to do with their surface area. They don't have as much temperature regulation. Once they lose that, they've got more surface area. A little bit of background on burns is just where we've got the transfer of radiation, thermal, or electrical energy that the body cannot handle. So thermal burns occur when the skin is exposed to temperatures higher than 111. Most time you'll be able to see that burn on them. You're not going to be like, oh, okay, you were only burnt with 109 degrees. I'm not going to worry about the actual number. The severity of how bad it is going to be based on how truly hot it was, whether it was a fire, whether it was scalding water, the concentration, how much was in that one specific area on their body, heat energy from the object itself, and then how long were they exposed to that temperature. So it says the greater the energy, the deeper the wound. The longer they're exposed to it, the worse off they are. And most people in general, when they encounter something like that, when they encounter something hot, what do? They try to get away from it. So like we were talking about, that barrier's been compromised. They have a high risk of infection, hypothermia because they've lost their temperature regulation. They're going to start losing fluid as well, start leaking plasma. They could be bleeding from other injuries as well, and then shock sets in. Burns of the airway are super important, mainly because when we have burns, just like anything else, something starts swelling, the airway swells up, the patient can't breathe. So anytime you have any singed airways, soot around the mouth or the nose, something to consider is controlling that airway, whether we put in an eye gel, have the paramedic put in a ET tube, whatever we can to make sure we have that airway before it closes up. And at the same time, like it says down there, there's circumferential burns all around, whether it's all around the chest, compromising how well they can breathe, or whether it's around an arm or a leg that can cause that crush syndrome we were talking about earlier. So, severity of burns, first, second, third degree, depends on how deep it was, how long, which areas are involved. If they have any other medical issues, like I said, diabetes is a pretty big one most of the time, just for the healing factor alone. And then whether they were extremely young or, I say extremely old. It's not. 55 is not very old. So there's your depth. Superficial first degree, that's your sunburns. Partial thickness, that's where you're starting to get those blisters. And then full thickness is the entire depth of the skin. That's where you get that charred black. So there's your different types. So we talked about what to use to measure these burns. The Palmer rule, using the patient's palm of their hand for the percentage. Rule of nines. Just bear in mind that for kids and infants, it's different than it is for adults because their bodies are developing at a different rate. Okay. You always include the partial thickness and full thickness. You don't use the first degree, they don't count. So there's your rule of nines for adults and for kids. So notice that it changes a little bit. Especially with infants in that head. So like we said, assessing them, classify the burn. Was it a thermal? Was it electrical? How deep did it go? How much percentage of the body did it burn? Again, scene safety. Obviously, if something's on fire, we don't necessarily want to be near it if we're trying to take care of folks. Fire's bad. We don't want to be near it. So make sure.
What if we don't know? What if we don't know, like where the burn came from, or like what caused the burn?
Then we just go off of what we see. You say, well,
Okay.
this third degree appears to be a third degree burn. Ideally,
Okay.
most of the time we should know just from the nature of being involved. But you know, to question, sometimes we don't. Sometimes we may just find this person and they have burns on them. We have no idea what happened. Do the best you can with
Okay, thanks.
So a lot of it still goes with seeing size up in that first primary impression. We're going to try and get information from the patient. Hopefully they can tell us. If not, it's okay. We can gather information from the environment. Make sure that there's not any other patients, especially if we're dealing with burns most of the time. It could be a house fire. There could be other patients. There could be additional problems, not necessarily just from being in the fire. It could be somebody had inhalation injuries from standing nearby, being nosy. You never know. These ones, we want to make sure that we call for resources as early as we can. Okay, most of the time, we'll have 3 or 4 patients. Most of these will be high-level critical patients that only one crew can handle. So the earlier you get your resources to you, the better. And then just remember, like we said, most of the time their chief complaint is going to be, I'm on fire, not I have 2 broken legs and I'm on fire. Just be aware that you may have to hunt for some other injuries once you get them to stop burning. So rapid exam, same thing as earlier. You need to get your general impression, ABCs, whether they're alert or not, and any life threats. Obviously, if they're burning, we want to stop them burning. Talk about this a little bit. Singed facial hair, sit around the airway. Those are signs that we need to be extremely vigilant in looking at the airway and keeping an eye on it. Obviously, if they have some major life-threatening bleeding, we probably need to take care of that first. Doesn't matter if we get a secured airway, if they bled out from losing a leg or anything like that. And then keep an eye out for shock. Most of the time, that will happen. Rapid transport, same thing with the other injuries we were talking about. If there's any airway issues, breathing issues, if it's an extremely significant burn, if they have major external bleeding, or if you see any signs and symptoms of internal bleeding. So that darkening, bruising of the abdomen, if they're starting to get tender, if they're getting rigid in the belly, things like that, we need to consider trying to get as rapid a transport as possible. At the same time, calling for help, calling for ALS providers that can give fluids and give pain relief. So going back to chief complaint, if they were in a confined space, you can pretty much guarantee that they had some form of inhalation injury. If we can get medical history from them, great. That always helps with figuring out if there's going to be any difficult issues coming across when we're trying to treat these patients. Get your sample, signs and symptoms, allergies, medical history, last meal, and the events leading up to. Hopefully they can answer those. That, for one, means that they're alert. At the same time, ask those other questions. Are you having difficulty breathing? Is it hard to swallow? She asks them if they're having pain. Most of the time, they're going to tell you yes. That bottom part, that's really good, especially if they can't answer it for us. Those medical ID bracelets give us a clue of medical history, what we may be encountering. Because the whole situation could have started with they were cooking dinner, they're diabetic, and their blood sugar dropped, they passed out, and the house caught on fire. So not only do they have the burns we have to worry about, but they also have the low blood sugar that we need to treat. So kind of keep an eye out for things like that. Physical exam, same thing as earlier. We're going to assess head to toe, decap VTLS. It's probably been a while since we've gone over it. Deformities, contusions, abrasions, punctures. Wow. Deformities, crepitus, abrasions, punctures, bruising, tenderness, lacerations, swelling. At the same time, there was a TIC with it. They kind of combine that with the BTLS part, but also look for any instability for the chest or the hips. That way you kind of know if there's going to be any breathing problems or if there's any significant bleeding from fractures. Like I said, it's a rough estimate. Okay, we're not looking for a guaranteed, this is 33.3% burned. Nah, this looks like it's 27%. That's significant enough. Okay, good deal. Just guess on it. If it looks bad enough, it's bad enough. At the same time, we can classify the burn, get the severity, perfect. It will just help the patient more when we get to the hospital. And package them up, whether they're being transported by ground or whether they're getting transported by air. Most of the time, if it's over 27%, probably want to consider a burn center. Again, communication, documentation. We can tell them how the burn occurred, great. But we do need to tell them the extent of it and if there were any specific areas. Okay? Talking about like your airways, genital areas, those kinds of places are specific that we need to get other specialists involved with. All right. Thermal burns. Is everybody good? Does everybody need it? Anybody need to take a break for a second?
I'm good for now.
I'm good.
I'm good.
Let's see. Who else do we got in here now? I've got some.
I'm good.
I'm good.
I'm good.
Good.
I'm good.
Casey, are you
Good. I'm good.
Casey, are you present?
Yes.
Yes, I'm here.
Very good. I just want to make sure we got everything that you're here. That way we can
Oh.
keep it on the record.
Okay.
So, thermal burns, obviously.
I'm good.
Okay. We'll keep going then. Thermal burns are caused by heat. That's scalding water, open flames, contact burns from hot stoves, like that. Steam burns, that's your scalds, and then flash burns are your explosions. Right? Management, we talked about a little bit already. We want to stop the burning, right? We want to stop them from burning. We want to cool it down and get all the jewelry off, because they will stop. Always keep that thought in the back of your head that the patient might have in your way. Even if they said, "Well, I didn't breathe anything normal," even if they're talking normal, that may be fine. The main things you want to look for is if they start having that high pitched sound, stridor, talking, or if they're having voice. Anytime
Daniel, would you mind muting, buddy?
Let me see if I can get him muted. And it's the dry dressings for these folks. Doesn't necessarily have to be sterile, because they're going to get a buttload of antibiotics anyway because they just lost their protective barrier. We're going to assume they're going to have an infection anyway, but we want to keep them covered. Not just to prevent anything else from getting on them, but we're trying to retain the heat because they just lost that temperature regulation. All right, so like we said, inhalation burns. Upper airway is going to be that superheated gas. The lower airway is going to be those chemicals. Lower airway is usually associated with wheezing. Upper airway is the stridor. Now we've been saying that's upper airway swelling that always needs to be taken care of quick. Good thing to have with you is that emergency field responder guide that has all the chemicals in it. A lot of times that'll tell you what combines with what it does when it interacts with certain things. Definitely helps when you're trying to think of toxic gases and things like that. You can get it online from, I'll have to find the link for it and give it to y'all. I'll put it in the group me. But definitely a good piece of equipment to have. Not a lot of people go through it, which is unfortunate. So carbon monoxide, we've all probably dealt with this before at one time or another. If you got a lot of people that are complaining of a headache or feeling sick, always a good thing to start thinking about carbon monoxide. Downside with that is when we check their vital signs, they may still show a good O2 sat, even if they do have that carbon monoxide poisoning. So anybody that has a headache, feels sick, you've had some kind of issue at that house, whether it's fire or if there's 6 of them feeling that way, get oxygen on them as quick as you can. Hydrogen cyanide is definitely not something you want to breathe in. It's caused by combustion with a heat source. So with those folks, cyanide poisoning, we're going to try and decontaminate it as much as we can. Also protect ourselves and supportive care. That means oxygen, oxygen, oxygen. Those folks need to be transported quick. So chemical burns, that's anything that comes in contact with the body that's toxic. One thing that we really should focus on is eye protection. Okay, our eyes are extremely vulnerable. Okay, they don't have thick skin on them to protect. They don't have anything to block any of that stuff from getting in them. At the same time, we've only got those two. If we have something that gets in our eyes, guess what? They're not going to work anymore. So make sure you wear protective eyewear on calls, especially if there's some kind of indication for chemicals. Severity is related to what type it was, how concentrated it is, and how long we're exposed to it. And again, the hammer at home, we're wearing protection for this stuff. We don't go in there half cocked. If we can, we need to remove excess chemicals from the patient. If it's dry, brush it off before flushing with water. A lot of times when you use water, it can activate those dry chemicals. So do your best to brush off absolutely everything if you can. Same time, get these folks' clothes off. Okay? Our clothes can hold all kinds of different, in the nooks and crannies of our shirts, pants. We need to get that stuff off so we can make sure we get all the chemical off. If they've been in contact with some kind of liquid, we need to flush it with water. 15 to 20 minutes. If you got it in their eyes, you're probably going to have to hold their eye for them and then flush their eye. Same time, if you've got a saline bag and a nasal cannula, you can kind of hook it up to where the nasal cannula will flow that saline into their eyes and flush them out. There's a couple good videos on YouTube for it. Definitely something to look at. Electrical burns. So high or low voltage, doesn't matter. Come from either source. So an insulator is anything that obviously prevents that circuit from being completed. A conductor is something that allows the current to flow. Unfortunately, we are pretty decent conductors. Again, same thing with the thermal and chemical. The current, magnitude of it, and how much voltage was there can determine that seriousness of the burn. And again, scene safety. We want to make sure we're safe. If we've got somebody that's been electrocuted from down power lines, we obviously don't want to go near it until it's secure. Most time with electrical burns, you're going to have one way in and one way out. Okay, may not always come out close to the entry wound. Problem is, once it goes through, it causes a large amount of damage to things we won't be able to see. At the same time, our heart runs off an electrical system. We have a high potential for this electrical shock or burn. Hang on. Oh, okay. This mic lost internet connection. But we have potential for cardiac arrest for that electrical burn to short circuit our system. So just be aware that even if they had a small shock, it may still be significant. And that's what one of them could look like. Definitely something we need to cover up. So again, if indicated, do CPR. Obviously, if they're in cardiac arrest, put the AED on, do the CPR. Give them supplemental oxygen, bandage up the wounds. These folks definitely need to be transported quick. Just about everybody that we're discussing needs to be taken to the hospital immediately. Tasers. Same thing with electrical burns. Tasers can also cause cardiac issues, especially if they have any underlying issues like any previous heart conditions, high blood pressure, things like that. Make sure you have the AED with you if you can when you're taking care of those tasers. Radiation burns. Main thing with this one is scene safety. Okay. You need to make sure if they have had some kind of radiation exposure that if it's ongoing. If it's ongoing, you need to take care of yourself first. 3 different types of radiation. Gamma radiation, that's your x-rays. Main thing, maintain a safe distance. Additional resources, most times specialized for these folks. And then you're going to do your ABCs and treat just like we've been talking about. Definitely let the emergency department know that we've had some kind of radiation issue. If you can, limit your duration to that exposure. Park the ambulance, park the truck as far back as you can within reason. And get something else, potentially a building, to block the radiation between you and the patient. Seems kind of the opposite of what we usually talk about when we're trying to get to patients, but radiation is no joke. So all wounds require bandaging. We've all seen different types. We've got triangle bandages. We have Kerlix, 2x2s, 4x4s, abdominal pads. We've got moist dressings, you name it. Main thing they do, obviously, control bleeding. They keep anything from getting further damaged, and they prevent further contamination and infection. Most of that kind of should be second nature to all of us at this point. Dressings are just good for covering large open wounds. 4x4s, 2x2s, that kind of stuff, good for smaller wounds. Okay. We talked about occlusive dressings with chest injuries. Like it says there, it prevents air and liquid from entering or exiting the wound. Once we get these dressings on, we kind of need to take care of them and stabilize them, make sure they're not going to fall off, come apart. So you use those rolls of Kerlix, triangle bandages, tape, wherever we can. Elastic bandages probably are not best for that. They don't necessarily hold it together very well. And like I said, if it continues to bleed even after direct pressure for 5 to 10 minutes, go ahead and put a tourniquet on it. We'll do a little bit of review real quick. Young male struck in the forearm with a baseball bat or baseball. Points of pain in the area. He's got slight swelling and ecchymosis present. He's got no external bleeding. So which type of injury does this describe? Y'all can just unmute and answer if you want. We'll just do it like we used to do, where everybody just kind of calls out the answer.
B.
I go with B.
Okay.
B.
All right. So, yeah. So contusions, that's those bruising. Abrasions are those scratches that we were talking about, kind of like drug burn. Hematoma is that swelling, blood in it. And avulsions where it peels those layers back. Compression injury that is severe enough to cut off blood flow. Which one might that be? So we've had some kind of force compressed.
B. D.
C.
B. No, C.
Yes, C.
Because you're cutting off the blood flow.
I think it's like when that tree comes down on the leg, it blocks all the blood flow. And what happens is it starts swelling up. That's the ones where they may have to cut the patient's leg or whatever open, kind of ease that pressure off of them before we end up having the buildup of lactic acid. At the same time, he's not necessarily a baddie. He's trauma related, but you could have a significant clot that could lock up something. You could have those DVDs. 45-year-old shot right into your chest. You got a wound that has blood bubbling from it every time the patient breathes. What do you need to do?
Hey.
Found out how y'all cheaters are cheating now.
Yeah, I know it's got that on there. Oh, well, that's all right. Yes, hey. If that's something you step in, we're going to do that.
Just noticed it.
These are those ones that we're going to burp the wound. That way, if it gets too tight, you can kind of lift up that one piece that you didn't tape down and let the air out. But we don't want air coming back in. Like it says, effects of ice on the hematoma, it's going to reduce it, right? It's going to constrict those blood vessels and hopefully decrease the bleeding. Sterile dressing ideally, but any kind of dressing put to an open injury is obviously to control the bleeding. Like we said, we're already assuming that the injury itself is contaminated. That sterile dressing is not going to magically remove any of the previous contaminants, but it is going to stop the bleeding. All right. Covering an abdominal wound with some bowel poking out. Obviously, we are not going to poke it back in, right? Never stick anything back into the body. We're going to put the moist sterile dressing on it, secure it with an occlusive dressing. The one poking stuff back in, our fingers are dirty, even if we have gloves on. Poking it back in could run the risk of infection. We could also rupture it just from putting that pressure on it. The reason we do a moist dressing is our body's kind of a humid environment, isn't it? We don't want to dry any of those organs out. 20-year-old male attacked by a gang. He's got a large knife impaled in the center of his chest. So it doesn't really tell you as much information as it should. Now he's apneic and pulseless. Can we do CPR with the knife there? No. We need to go ahead and remove it. Hopefully put something down, try and control the bleeding, and then CPR. So which one's the severe burn? It's going to be your bottom one, that 5% full thickness. Anytime you have any full thickness burn, it's going to be severe. Okay. Five-year-old boy was burned when he pulled the barbecue grill over on himself. Partial and full thickness burns to his anterior chest, circumferentially on both arms. So what percentage of the area has been burned. That's where we can use that rule of nines on him and be 27%. At the same time, it says it's circumferentially on both arms. What do we need to worry about? I kind of talked about this earlier.
Compartment syndrome?
Yep. Have that swelling from it. Something extra to think about. Which is following about chemical burns is false. Obviously, it's pretty glaring. We're not going to put water on top of a dry chemical. We're going to brush it off first. All right. Does anybody have any questions for that first chapter?
Nope.
Nope.
Okay.
Nope.
I'm going to go ahead and stop recording. Resume the recording. Everybody that was in the previous one still in here. So we'll just continue on with it. All right. Let's go ahead and do chest injuries. Main thing with this is we got some super important organs in the chest. As we got our heart, lungs, major blood vessels. A lot of these can be affected by blunt trauma, penetrating trauma, both explosions, you name it. We always want to consider those injuries that are going to impair breathing function. You know, your sucking chest wounds, impalements, collapsed lungs, things such as that. So the difference between ventilation and oxygenation. Ventilation is the actual physical process of moving that air in and out. Oxygenation is the kind of the metabolic part, where the oxygen is being delivered through the diffusion. Just remember the chest extends down from the neck to the diaphragm, which is the muscle there at the bottom of your abdomen. A little bit of EMT on it. The two lungs, your heart, and that diaphragm on the bottom. Pleura covers each lung. That's where pleurisy comes from, is that inflammation. We also have that small amount of fluid in there. That way we don't have any friction when we rub up against our lungs, rub up against the chest wall. All right, we just talked about the bowel organs protected by the ribs. So medium contains the heart, your greater vessels, the esophagus, and the trachea. So all the upper portions of your chest. You just have to keep in mind that a thoracic aortic dissection can develop right there. And the diaphragm separates your thoracic area from the lower part of your abdomen. So we're talking about the mechanical portion of ventilation, talking about those muscles between the ribs contracting during that inhalation phase. Okay, the diaphragm contracts up so you can pull in air. And they relax once we exhale. The main thing to think about is the body shouldn't have to work when it's in a resting state. So you shouldn't have to see accessory muscle use during that time. Best indicator or best thing to talk about when accessory muscle use is like kids. When they're not feeling well, when they've got asthma or they've got pneumonia, anything serious, they start doing that belly breathing. you start seeing those muscles pull, those retractions of the intercostal muscles, that's a really bad sign that people are having trouble to breathe. All right. So that's what everything looks like when you inhale and then when you exhale. So notice that the diaphragm here is coming up. There's your liver. Diaphragm there. So we work on a negative pressure system. So anybody that has an injury below C5, they can still breathe with that diaphragm. Say C1 through 5, stay alive. Kind of a dumb phrase, but it helps you remember where that point is. Because anything above that, they may not be able to have the muscle control to continue breathing. They'll be stuck on a ventilator. So your minute volume, it's the amount of air moved in the lungs in 1 minute. Normal tidal volume times the respiratory rate. Tidal volume for a adult is usually around 600. Most time, people that's got a decreased tidal volume are going to obviously have an increased respiratory rate because they have to keep that minute volume up. Same thing with other injuries. Chest injuries you can have open or closed. Both are pretty significant when you're talking about the chest, mainly because of the organs we have there. So closed chest injuries, we need to start thinking about cardiac pulmonary contusions. Cardiac contusions can simulate heart attacks. They might look like they're pale, sweaty, diaphoretic, blood pressure's low. If we have any bruising in the lungs, obviously difficulty breathing. Rib fractures can also cause a lot of problems. Anybody remembers we talked about flail chest, flail segments, where pieces of those ribs can break off and cause extreme amounts of pain and difficulty breathing. Things to consider. Obviously, open chest injuries is where something punctures and creates an open wound. Like I said, don't try to move it or remove it. If it's there, stabilize it, unless you have to do CPR and it's in the way. Now, if it's in the side of the chest, like that one looks like, we can do CPR with that still there. Secure it and continue on. There's a couple different injuries that blunt trauma can cause. Just be aware of the signs and symptoms for shock and what to look for. Bruising, crepitus, pain, and difficulty breathing are probably going to be your most significant indicators. Penetrating injury, if you can't figure out if they have a penetrating injury or not, we'll have to talk at a later date. Most of the time, you better be able to see whatever is puncturing their chest. We talked about hemoptysis, blood from the mouth. Keep an eye out for if one side of the chest is coming up and one isn't. It's going to be a good indicator of some kind of trauma or a breathing issue that we're going to have to take care of fairly quick. And obviously look for low blood pressure, rapid pulses, and if they're turning blue. A lot of times, especially with like flail chest and injuries like those, they won't want to take deep breaths because it's going to hurt too much. You don't take a deep enough breath, you don't get enough oxygen. So a lot of times once we take over for them and help them breathe, those issues get addressed pretty easy. Scene safety, we've kind of gone over this before. If this was an assault, gunshot wound, stab wound, fight, whatever, try not to mess with anything if possible, except for the patient. At the same time, make sure you're safe. Let them go in first, contain the situation, then go from there. If you need to, consider putting an X collar on, especially if you have bent steering wheels in NBCs, if they fail, any kind of industrial accidents. Most time, erring on the side of caution is a lot better. Now, if they have an isolated injury, like they were only stabbed in the chest, and that was it, obviously you don't need to put an X collar on. Primary assessment's the same. Okay, we're looking for everything we can in the same style of assessment we did for the soft tissue injuries. Make sure they're breathing. How are they breathing? Are both sides coming up at the same time? Is one side popping up more than the other? Is there anything bubbling? Look for all those indicators. So there's your deadly dozen chest injuries. Obviously, number one, airway obstruction is kind of a given. If they've got something blocking the airway, they can't breathe. Bronchial disruptions, same thing. If it's swelled up due to asthma or from some kind of injury, if we've had a bronchial tear, they're not going to be able to get that oxygen exchange. Diaphragmatic tears will affect how well we can breathe because we've kind of lost that negative pressure portion. They may still be able to do some of it, but it's not going to be near as effective. Esophageal injuries, you could have somebody that has a tear, open tension, and massive pneumo and hemos. So the pneumothorax is going to be from air, hemothorax is blood. So tension pneumothorax is where we've got that injury, lungs popped inside the chest, but there's no way for the air to escape, so it just continues to fill up the chest cavity, pushing over the other lung, pushing over the heart. That's where you're going to get all those shock symptoms. They're going to start having trouble breathing. Their blood pressure is going to get low. Their heart rate's going to slow down. They'll also have that tracheal deviation. Just be wary that tracheal deviation is a fairly late sign with this. If you're seeing that, you really need to do something very quickly for that patient. Those are the ones that will have to decompress the chest with a needle. Again, hemothorax, that's just where the chest is filling up with blood. Not much we can do for it anyway. They're going to need to get a chest tube and get that drained in the hospital. Flow chest, that's where that piece is broken off from the ribs. Most time a bulky dressing will help that, and positive pressure from us, giving them ventilations. Cardiac tamponade, that's where the sac around the heart fills with that excess fluid. Most time that's just going to cause the heart to stop beating. You won't have enough space to beat. Again, not something that we can do anything for on the truck. Those patients need immediate transport. So that thoracic aortic dissection, depending on how bad that is, may not even matter. But they'll get that tearing sensation in their back. And then we talked about the myocardial and pulmonary contusions, the heart and lungs. Trouble breathing may look like a heart attack. Again, the assessments are pretty much the same as before. Try and get a sample history if you can. Make sure you've got their signs, symptoms. Pertinent negatives are always good. Okay, if they've had a hit to the chest, but they're not having any chest pain or they're not having any trouble breathing, those are good things to put down. Patient denies shortness of breath. Patient denies chest pain. Okay, that way if something does come up later on, well, they had a hemothorax and you didn't say anything. Well, they said they weren't having any trouble breathing. Kind of covers your butt there. Physical exam, same thing. If it's truly an isolated injury, you can focus on that injury, patient's complaint. Make sure you get all your information for it. Try and be as thorough as you can and as detailed as you can. With that in mind, if they're having these chest injuries, but let's say they're in an MBC and they have other extensive injuries, do your rapid physical exam first. Make sure you treat the life threats first and then go from there. Again, most of these folks, we're going to reassess every 5 minutes or pretty much every time we lay eyes on them. Okay, we're probably not going to leave their side, especially if they have these major injuries. Again, reassessment, same thing. We're going to check everything we've done, double check their chief complaint, check their airway, breathing, pulse, perfusion, bleeding, see if our interventions have worked, see if anything's gotten better, see if it's gotten worse. Main thing, aggressively treat the shock. We want to make sure we try to avoid that blood pressure dropping to the point where it won't come back up. Because we have compensated shock, decompensated, and irreversible, right? We want to try and avoid those last two. We do that, for one, by not delaying transport unnecessarily. So pneumothorax, we were talking about this. It's where you get air in the pleural spaces in the lungs. When you listen to that side, you may not hear breath sounds, or they may sound kind of far off or diminished. That's what it can look like. Open chest wounds, that's the open pneumo. That's where we have an open portion of the chest, like a gunshot wound or a stab, that the object's no longer there. A lot of times you may see some bubbling coming from this. That's the air entering and exiting those wounds. The main thing we want to do is seal that up. That way nothing else can get in there and we can control what comes out. Because once we seal this thing up, if we sealed it on all four sides, we'd create a tension pneumothorax with it. We'd let that lung space and chest cavity fill up with air and we cause problems. So that's why we only do the three sides and let it kind of burp it. Does that make sense so far?
Yes, it does.
Yes.
Yes.
Just making sure. It's a whole lot easier when I can see y'all sitting there shaking your head yes in the theater. It's a little different on the computer. All right. So there's your open pneumo. Like we said, air is coming in and it's coming out. Most times, simple pneumos we don't necessarily have to worry about. I mean, they're significant injuries, but they're not going to cause any immediate life-threatening problems. They do have a tendency to change into tensions eventually. Something to keep in mind when we have those. We just need to, if we notice that they don't have any lung sounds on one side or they're diminished and they're not showing signs of shock, we may need to plan on them having signs of shock soon. Like I said, tensions, that's where that air is getting in there and it doesn't have anywhere to go. It just kind of increases and increases and pushes everything to the side. Just like that picture. That's where we'll place a needle in the chest and kind of relieve that air. Hemothorax, like I said, that's where blood's filling up that cavity. Again, we can't really do anything about that. We need to get him to the hospital. So if you can hear lung sounds in the top, but all of a sudden you can't hear sounds in the bottom of the lung space, it's probably safe to assume that they're going to have a hemo. And tamponade, it's where that sac around the heart fills with blood, fluid. Main thing we can do is make sure they're breathing adequately and get them to the hospital. They'll have to insert a needle in there and drain the heart. We cannot do that. I don't want to do that. That's scary stuff. You can really mess that up. That's what that'll look like on the right-hand side. So rib fractures, fairly common. Old folks especially, they get brittle bones. They fall, they have a tendency to break things more often. That being said, if you have fractures in the upper ribs, usually a pretty good MOI. Okay, it takes a little bit more to fracture those ones. At the same time, they're a lot closer to our heart, to our lungs. Y'all give me a second, I'm gonna close this door so we don't hear the cleaning lady. Okay, that's a little better. And we don't hear it rattling down the hallway. Right. These folks, we want to make sure we give them plenty of oxygen. A lot of times these won't be super significant on their own, but they are painful. Most time when people are in pain, they have trouble breathing. That flail chest, that's what I was talking about. Pieces of that chest wall will come detached. You'll see it where they breathe in and breathe out. They'll have a piece that moves opposite of what they're supposed to be doing. Again, pulmonary contusion, same thing like with the heart. If they've got a flail chest, it's probably safe to assume that they'll have some kind of pulmonary contusion. Main thing for both of those, just oxygen and ventilation. They'll probably need the help. They'll probably welcome you getting a BVM out and assisting with their ventilations. Sternal fractures, definitely a big consideration for organ injury. It's a little harder to fracture that piece. Clavicles can have a tendency to have pneumos develop from it. Just be aware of all those different types of fractures we can have. Traumatic asphyxia, we've got distended neck veins, cyanosis, which we know from all the terminology we learned way back when. That's lack of oxygen, blue in the face, neck, and then they might have the vessels in their eyes bust. Usually it's sudden and severe compression of the chest that causes that. If we can, we provide oxygen and ventilation, transport immediately. Again, blunt heart injuries, we get bruising on that heart muscle. Same thing, monitor vital signs, oxygen, ventilations if needed, get them to the hospital. All right, so I know we talked about this at one point. Back when that commotio cordis, this is where they get hit right at that sweet spot when the heart's beating and they drop dead. That's somebody gets hit with a baseball and they drop down to the ground. Most of the time, if we can get there, get them defibrillated in those first 2 minutes, we get really good response from them. Very rare for this to happen, but it's out there. So just be prepared that if somebody gets hit by something, they just drop like a sack of bricks. That may be what happened. All right. So laceration on those great vessels, obviously, those large vessels carry a lot of our blood volume. So if they are torn up, get lacerated, we can dump our blood volume pretty quick. Main thing we do, monitor and treat for shock, take care of the blood pressure, take care of oxygen, get them to the hospital, and be prepared for CPR. All right. So chest impact steering wheel during motor vehicle crash, deceleration, injury which often kills patients, usually within seconds. Which one of those do you think y'all think that one is?
B.
Okay. Everybody fairly good with that answer?
B.
Yeah, B.
Yeah. So like we said, if that aorta ruptures, it really ruptures, you're going to dump that out. I think we said 7 seconds or less. Very quick. They'll feel a very, very sharp tearing sensation, and that's probably the last thing they're going to feel. Everything else could probably happen during that time, but most of those we can take care of. Signs and symptoms of a chest injury include all the following except what?
B.
B.
Yeah,
I'm gonna say A.
close.
Wrong.
So remember, they're coughing up blood. So if we're coughing up blood, most of the time that's coming from the lungs, which can be an indication of like a hemothorax or some kind of injury to those lungs. If we're vomiting blood, it's usually coming from the stomach. We'll think more of a GI issue or an abdominal injury. Does that make sense?
Yes, it does.
Most of the time, if somebody's vomiting blood, it's probably going to be a little darker. During assessment of a patient stabbed, you see an open wound to the left part of the chest. Most immediate action would be to what?
D.
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 The B is not necessarily wrong. Yes, we're going to transport this person immediately, but we need to cover that open wound. Because if it's up on the chest, that open wound is probably going to affect their breathing. You might not be able to breathe adequately enough to survive transport to the hospital. So what we'll do is we'll cover this one up with that occlusive dressing, and then hook them up to the monitor and a haul butt.
Woo.
Does that make sense?
Yes.
Look at that ugly bald head.
Sounds of jealousy.
All right. So Care for a patient with signs of pneumothorax, your most immediate concern should be what?
E. C.
D.
We got a B, C, and D. Anybody want to pick A? Just go ahead and round it out.
A.
I kind of like A.
There are pneumothorax is where that air is coming into the chest, right? Whether it's a simple or a tension. So we're probably looking at their ventilations are going to be impaired. So that's the immediate concern. Yeah, that's the thing we need to take care of first and foremost. They may have those other injuries, but if they're not breathing, or if their heart's not beating, those are the two things we need to take care of first. So our purpose is a one-way flutter valve serve, and we're dealing with an open pneumo.
D.
I was going to say B as
B.
well.
Yeah, B.
Bill, all right. So it has those two uses, okay? So we're taking the air that's trapped in there and letting it escape, and at the same time we're keeping air from entering it once we breathe in. That way it lets that lung re-expand if it can. So signs of cardiac tamponade include all the following except this one wasn't initially gone over. You guys might have to do a little bit of thinking on this one. So the cardiac tamponade's filling up the sac around the heart.
D.
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 Some B's and D's.
C.
There you go.
Oh,
Boom! Where's my other C guy at? That's what I'm talking about.
So the problem with B is they're probably going to have a weak rapid pulse because they're going to start
oh,
going
collapsed.
really quick.
That's the word.
And then with D, that narrowing pulse pressure, the heart's not able to contract and it's not able to fill up near as good. So those numbers, your systolic pressure and your diastolic are getting closer. They won't necessarily have those collapsed jugular veins. They're going to have backup. They're going to kind of be backflowing all that blood because it's not pumping as well anymore. So you see that distension for the jugular veins. So they won't be flat. They'll be probably completely full. Patient experiences severe compression of the chest. They're trapped between a vehicle and a brick wall. You suspect traumatic asphyxia due to the hemorrhage in the sclera of his eyes, and which other sign?
E.
B.
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 All right, deal. Yeah. Most time, if we're blocking off the chest, face is going to start turning blue because we're not getting enough oxygen to it, right? We'll also have those distended neck veins.
Yeah, C. Like what you were talking about.
So they could very well have asymmetric chest movement depending on what damage was done to it. It doesn't really go into detail. But most of the time, if we're thinking traumatic asphyxia, they're going to have those busted blood vessels in the eyes. They'll have the distended neck veins, and then they'll have that cyanosis in the head, the neck, probably the upper chest as well. Those will be the ones that should jump out at you. 14-year-old
Is
baseball
that
player,
also a compartment syndrome thing?
it's possible. It's such a. Has anybody seen traumatic asphyxia before in the field or anything?
No.
It's definitely interesting. Eventually, it could probably create a bit of compartment syndrome, but the main concern is going to be the lack of oxygen. They're gonna die from not being able to breathe and fully expand that chest before the compartment syndrome would even take effect. So we got baseball players hitting the chest with a line drive, and he's in cardiac arrest. Which one of those is going to be the correct explanation for what it is?
C.
Hey,
Ooh, I got my mute off. B.
See,
A.
Hey,
So it's going to be C.
It's C.
It's that commotio cordis. This is where they.
Ow.
So they could very well have that contusion. Okay, they could have bruising on the heart. But the thing is, even if they have the bruising on the heart, what's happened is they've been hit so hard and in such perfect timing that their heart's no longer beating in the first place. So that's going to be your main concern. But it's called commotio cordis. Again, very rare, but they need to be defibrillated as quickly as possible.
Could that occur in hand-to-hand combat?
Can it occur? I mean,
Yes.
I guess if you punch in the chest at the right time. I don't know. I haven't really gotten enough fights where I've punched somebody to death. Paradoxical chest movement. Typically seen in patients with what?
hey,
A.
hey,
Right.
Yeah. Flail chest. That's where you've got that piece that's popped out. So it's going to stick out when we breathe out, and then it's going to suck in when we're taking a breath. Like I said, most of the time with these, we need to put some kind of bulky dressing on there and then help them with positive pressure. Kind of ease because they're not going to want to take a deep breath because that's going to be extremely painful. All right, 40-year-old man, unrestrained driver of a car that hit a tree, struck the steering wheel with his chest. It's got a large bruise of the sternum and a regular pulse rate of 120. Should most be concerned about what?
B or D?
D.
D.
Okay, it's B's and D's.
I'll say A.
Okay. Yeah, it's going to be A. So remember, the sternum is right over the center of the chest, so not necessarily where our lungs are at. We run the risk of that heart muscle being bruised. They may have other injuries with it as well. If we see somebody that's got an increased heart rate like that, most likely they're going to be sweating, cool and clammy, blood pressure may be low. It'll almost have a lot of the indications like a heart attack would. All right. Made it through that one. So everybody's still here from the first set? All right.
Yeah.
Yes.
Yep.
Yes.
Yep.
Yes. Yes.
Yep.
Yep.
We got our abdominal and fiduciary injuries. Main thing with the abdomen is we've got a buttload of organs in there too. Just like we had the lungs and the heart. In our chest cavity, we've got a lot of organs. In the abdominal, we've got your liver, your pancreas, your stomach, your kidneys, your spleen, your intestines, all that good stuff. All that stuff that can be injured and bleed and cause significant problems. Main thing with this is to know where your organs are in what areas of the body. That way, if they're having pain or bruising in the left upper quadrant, you know what's there. If you know what's in the right lower quadrant, if they're having pain there, what kind of organs can be affected from that. Hollow organs, you got your stomach, your intestines, the ureters, the bladder. Most time they're collecting stuff. You know, they've got your digestive food, urine, bile. Bad thing with this is whenever they're busted open or cut, those contents can come out. And a lot of times you'll run the risk of an infection. Blood supply for the intestines comes from the mesentery. That's that stuff that connects the small intestine to the abdominal wall. If you have a mesenteric tear from a traumatic injury, you can bleed into the cavity, so in your abdominal cavity. Depending on how bad the bleed is, you may not even notice it until it's significant. So we've got a lot of space in the abdominal cavity. We can bleed out probably 2 liters before we start even noticing them. So here's your A&P of where all the organs are at. Notice the liver covers up quite a bit of that right upper portion. Spleen's over on the other side. Just make sure if you're dealing with somebody that has an injury in a specific spot, you know what can be affected. Solid organs, livers, your spleens, pancreas, kidneys. They're kind of the hard workers of the body. They also have a lot of vessels that go to them. They're supplied by a lot of blood, which means that if they're lacerated or they suffer some kind of injury, you have a high potential of having severe bleeding. Again, same thing. You can have closed or open injuries to the abdominal cavity. They can involve both hollow and solid organs or either one. Again, blunt trauma, same thing. It's closed injuries, doesn't break the skin. A couple examples up there. So pain can be deceiving. Most time they might just have some kind of general, oh, I don't feel good. My stomach hurts a little bit. Or depending on what it is, they could have pain in their upper shoulder because some of the nerve endings are shared between different types of our organs.
I have a question. This is Caitlin. Hold on.
Okay.
Okay, so I actually, whenever I had surgery, whenever my ovaries ruptured, I had the worst shoulder pain. Is that related or is that in my head? People make fun of me all the time because of my shoulder pain related to my ovaries.
No, because a lot of your nerve endings will be shared. Same thing with like gallbladder. I think the gallbladder
Mm-hmm.
is with the left shoulder. That same
The
nerve.
left shoulder. Sorry, this is just, I don't know, information to me.
But no,
And
they share the same nerve pathway.
okay, that's good to know. Thank you.
It's called referred pain.
Take notes. Keith and Carlos isn't in this because he's not in this class, but they always make fun of me. So now y'all know.
We're with you.
Huh?
We're just messing with you.
Oh my gosh.
So a lot of times it's difficult to determine the exact location of that pain. Depending on what it is, those folks may have that guarding presentation where you get close to touching it and they'll tighten up and kind of turn away from you and say, oh, no, don't touch me. Okay. The distension is going to be from that blood or fluid or whatever was inside those hollow organs being spilled out. So if you're starting to get a tight belly, instead of being soft, you need to be real cautious. Probably get those folks to the hospital a little bit quicker. So bruising, discoloration could start out as just looking like a simple cut or scrape. Just be prepared that if that starts changing, if it starts getting discolored or getting darker, we need to move a little bit faster. Seatbelts can cause blunt injuries, especially if we have that rapid deceleration. If it's too high, if it's not sitting right, definitely causes injuries. Same time, if somebody's pregnant, it can really damage that bladder. Because that bladder is being pressed on already, it's being pressed down. Most of the time, that seatbelt's not going to sit over top of their belly. They're going to have it sitting underneath it. So, correct position is as shown on the bottom. So just be aware of that. So open abdominal injuries, again, same thing. If some object that doesn't belong in that portion of the body is introduced into it. Again, open wounds can be deceiving. Why? Because we can't necessarily see all the way in there, especially if that object's still there. Keep that high index of suspicion that there's something worse going on. And again, if it's stuck in there, don't pull it out. So there's your different velocities. Low velocity obviously is knives, anything edged weapons. They're not going very fast. Medium velocity is your small caliber handguns and shotguns. And obviously high powered is your heavy powered rifles. Those high medium velocity ones, like we talked about, they can create that pressure wave. That's what that cavitation is. You'll have that line going through where the bullet went through, but then you have that pressure wave that opens up the injury further. And again, with knife wounds and things like that, you may not always have those internal injuries being apparent. You may not know that when they stabbed that knife in, they punctured the liver. You may not know that till later when the knife's taken out. And anything, that xiphoid process right there, almost dead center in the chest, not only can it affect your abdomen, but it could also affect your chest as well, depending on the angle. eviscerations we talked about with soft tissue injuries, they can look pretty rough. They're going to be extremely painful. Don't push down on the belly. Don't touch it if you can avoid it. If something's stuck in that wound or it's stuck on those organs, don't yank on it. Just leave it, cut around it, and then cover it up with moist sterile dressings. Obviously, signs and symptoms are pretty much going to be the same thing as shock. First one is going to be tachycardia. That heart rate's going to increase. They're trying to compensate for the blood loss. They're trying to keep oxygen to those body parts to perfuse them. Eventually, it will go on. They'll start having that change in mental status. Belly's going to get tight, stiff, and then eventually they will code on you. Hollow organs, like we said, they're kind of containers. They're not going to be extremely vascular. They may not bleed as much, which means they may have delayed symptoms. Okay. Like we said, that stuff comes out, it's going to be more of an infection that we worry about. So when you think about it, the stomach and the intestines, we have all that acid in there that breaks down the food we eat. We spill that out into our open cavity near all our other organs that aren't prepared for that kind of stuff. It's obviously going to tear it up. Just be aware that one, penetrating trauma can do damage to both hollow organs and to solid. But that blood trauma might pop one of those organs. Obviously, if air gets into that belly cavity, it's going to hurt, right? Because air is not supposed to be there. It's going to push on everything else in there. Again, solid organs, we said they're extremely vascular. You just have to be prepared for an extreme amount of blood loss. Mainly from the liver. That one's our biggest organ in the abdomen. It's extremely vascular. It's got a whole lot of vessels supporting it. If that thing gets lacerated, bleed pretty quick. Spleen and pancreas are vascular as well. Like we said, most of these organs are kind of the workers of the body, so they have to be supported by all those vessels. Again, the diaphragm is that muscle that helps us breathe. If it's punctured, you can also have your bowels kind of invade that chest cavity, which the more stuff we put in the chest cavity, the harder it is to breathe. Anybody that has those injuries, that's something to think about. Old kidneys. Sure, there's quite a few of us that have been kidney punched before. Commonly, you might have some blood in the urine. Just be prepared for those. They can be fairly painful. When we're looking at these abdominal injuries, we may know exactly what the injury was, and if it was obvious, but we may not know how damaged things are on the inside, especially if it's closed. We may say, yeah, they got hit with a baseball bat in the stomach. That's significant, but we don't know if the force of it popped one of those hollow organs or if the sheer force tore the mesentery away from the intestines. We don't know that stuff. We can't see it. So be prepared for any kind of injuries. At the same time, we need to be looking during reassessment to see if anything gets worse. We can't ever kind of get lazy with it. These folks, like every other one, are probably going to be assessed every 5 minutes. Same time, if somebody gets hit in the stomach with a baseball bat and then they were hit in the face and they had their jaw broken, which one are they probably going to be more concerned with? probably going to be more worried about that broken jaw. So just keep vigilant, keep aware of what kind of damage can be done and which ones are going to be more serious to you as the provider versus what's more serious to the patient. A lot of times I'll tell folks like that the jaw injury would be what's called a distracting injury. It's significant and affects that person, but it's not the most important one. So don't let their distracting injuries distract you from the more serious problems. All right, so again, scene size up, like the other ones, make sure it's safe. If you need to consider spinal precautions, do so. NBCs, they've fallen. If they were hit by a car, even if they say, well, I didn't fall down, or I got hit by a car, pinned up against this wall, well, probably wouldn't hurt to put an X collar on them. Do your rapid assessment. Downside with abdominal injuries is they could have happened hours ago. It could have happened days ago. Like I said, guy could have said, well, I got beaten up, yesterday. And he's just now to the point where it's starting to be distended. Again, like it says there, don't get distracted looking for more stuff. If you can't obviously see it, then you're good to go. And always look for that external hemorrhage that's life-threatening. Or we have to stop the major bleeding before we can worry about if they're going to be able to breathe. After that, do your ABCs and then decide whether you're going to transport them quickly or not so quickly. Most of these folks, like every other one, probably sound like a broken record, but they're going to all be transported fairly quick. Okay, especially with abdominal injuries, a lot of these are going to require surgery. We aren't able to do that. Again, get their chief complaint, get the mechanism of injury if they know it, get your sample history if you can. It's always good to find out bowel movements and urinary output, especially if you're thinking kidney injury or intestinal injury. Because if they've got blood in the urine, we obviously know that could be some kind of kidney issues. Black tarry stools is usually because they have digested blood in their system. Okay, is that a previous issue, or is that because they got the snot kicked out of them? Stuff to keep in mind. At the same time, you may not be able to ask all these questions with these patients. You may be having to focus on addressing those life threats and managing shock. So like it says, when we're palpating these ones, if you know they're having issues in the upper right side, start in the bottom left. Work your way all around until you get to that one that's having the issues. Because if you start with that one that's having the pain first, that's all they're going to be thinking about when you're poking on the other sides. Again, if you find some kind of life threat, you're going to treat it. You're going to stop it. For your tenderness, bruising, swelling, instability, rigidity, all those trauma signs. Keep an eye on your vital sign trends. They may start out having a decent blood pressure. 5 or 10 minutes later, they could be bottoming out. Again, these abdominal areas, a lot of them are vascular. You may lose a lot of blood. If your mechanism of injury does kind of lead you to an isolated injury, you can focus your exam on that. At the same time, if the patient is freaking out, worried about, well, I've been hit in the stomach and the arm, I can't move my fingers, I think my arm's broke, time to assess everything just in case. Reassessment, same thing we were talking about before with all the other injuries. Double check your interventions, double check your vital signs, recheck the injury, recheck the patient's mental status, double check everything, and then communicate well and document well for these patients. Okay, the hospital is going to want to know quite a bit of information with them. The more information you're able to give them, the better the patient's going to do. They'll get the OR prepared. They'll be ready for surgery. Once you get there, it'll pretty much be a relatively smooth handoff versus if you only gave them, yeah, this guy got hit in the stomach. No, they're not going to do much for that. But if you tell them this guy was involved in an assault, he was hit in the stomach, he has tenderness in the lower right portion of the abdominal quadrant, is starting to get a little bit more rigid, he's had a low blood pressure and his heart rate's increased, they'll take that information more and they'll say, okay, we'll go ahead and activate the trauma team. Does anybody need a break, or are we still good?
I'm good.
I'm good. I say we finish this chapter before our
Good.
next
I'm
break.
good.
Okay.
Fewer breaks we take, better I am.
Closed abdominal injuries. Again, just like all the other closed injuries, we can't see inside. We don't know what all is damaged. These folks, we need to get them off scene, get them to the hospital so that they can figure out what's going on in there. Just be prepared to treat for shock. If they have had some kind of blunt abdominal injury, if you can, put them on a backboard, protect the spine. At the same time, if they're not showing any severe injuries, or if that is the only specific injury that they're hit, like we're using the baseball bat, may not have to use that. So penetrating injuries, again, unseen blood loss. We don't know how far in it went, if it's been pulled out a little bit or if it hasn't. We don't know if it was twisted around. We can't see, right? So always err on the side of caution, expect the worst. Double check for any kind of exit wounds. If they're open and there's nothing there, put dry sterile dressings, pack the wound if you need to. Otherwise, stabilize whatever's poking out. All right, eviscerations. Again, this is kind of like we're talking about those organs stick out. We're not going to put them back in. Preferably, we'll have gloves on. The guy looks relatively calm. Grabbing his intestines poking out. Main thing is cover those up. Don't poke them back in. Try and keep them moist, keep them warm if we can. Secure it. We don't want them getting infected. We don't want them drying out. So the judiciary system. It's the reproductive functions, waste discharge. Male stuff hangs on the outside, females is on the inside. There's your pictures for them. I assume everybody knows what these look like. I would say kidney injuries, they're not unusual. They don't often happen on their own. There's usually something else involved. Like I said, kidney punches. Had plenty of those as a kid. So start thinking of kidney damage if you've got any of these signs here, especially if they're having pain back there. Again, the bladder we talked about, it's a hollow organ. If something injures it, it could rupture. You just have to be aware that that's going to spill all that content into the tissues around it, into the peritoneal cavity. Again, that runs the risk for infection. Males, sudden stops can shoot the bladder straight off the urethra. Females, when you're in your later trimester, you could have bladder injuries or run the risk of more happening, mainly because everything's sitting on top of it. So fracture pelvis right there, that bone fragment punctures that bladder, and then everything spills out. We may not know it spills out. Okay? Again, that stuff takes a little bit of time. They'll be having pain, but we may assume it's from a fracture. We may not know that they have a ruptured bladder. Those patients need to be transported so they can get CTs and get surgeons looking at them for those repairs. Obviously, injuries to this are painful and obviously a great concern to the patient. Okay? Again, I don't really believe in it being rarely life-threatening, but if you have more severe issues or concerns, again, life over limb, we're going to forego treating that piece of equipment if we have some more serious injuries. Females, you got the internals, your uterus, ovaries, fallopian tubes are rarely damaged, except for the pregnant uterus. The main thing is those injuries can be pretty serious, not only because that it's enlarged, but you also have the fetus in there. You could rupture the placenta and cause severe bleeding from that. There's your external equipment. Very rich nerve supply, which means that they could have extreme pain. Same time, consider sexual assault and pregnancy with that. If they have bleeding, you're just going to put a absorbent pad there. You are not going to stick anything into that orifice. Same time, these are fairly important parts. Okay? People might get embarrassed when they have any injuries to these. Best thing we can do is be professional about it. Don't giggle, don't laugh, don't make fun. Privacy is super important. Obviously, don't strip them naked out in front of the truck. Put them in the truck. If you can, cover the windows. Give these people respect. We wouldn't want people looking at our stuff. They wouldn't either. Ideally, have an EMT of the same gender perform the assessment, one that keeps us safe from any kind of harassment issues or anything like that. And most of the time, folks are a little more, what's the word for it? Willing to have an assessment done if it's the same gender. At the same time, look for blood in the undergarments. If they have blood in their underwear or anything, if they tell you that they've been assaulted, try to make sure that they don't shower, or that they don't interact with anything. Keep their clothing as intact as you can. That way they can get that for evidence. Again, scene safety, we're looking for hazards. Downside is patient may lie to you about how this happened. They may tell you something that is a little more dramatic than, well, I tripped and caught my stuff in a zipper and caused this. They could change that to, well, I was assaulted. Just be prepared for stuff like that. Same time, we're still going to look for any life threats. Same time, don't avoid that area. You have to check that area as well. It could very well be the most life-threatening bleeding that you find on the patient. If it is, then you take care of it. And everything else, airway, breathing, circulation, still falls in line, same as the assessments before. Like it says, this stuff is life-altering, okay? usually requires a specialist to take care of those injuries. Okay? So just be aware of that. These little smaller hospitals that we have in our areas probably are not going to be able to take care of, an avulsed penis or torn up labia. Okay, they're going to have to be taken to one of the higher level facilities that may have one of these specialists there to take care of. Those are a couple of the more common complaints with these injuries. When we're asking for sample history, it's always good to see if they've had blood in the urine. If they have, it's a good indication of some kind of kidney injury. At the same time, we find out how much they've been drinking. If they've, had one bottle of water in the last 2 days, they may not have near as much fluid in that system. And sometimes this makes people uncomfortable when we have to assess these and treat them. Try and give them as much privacy as we can. Same thing as everything else. Identify any life-threatening bleeding. Do a full body assessment. If it's an isolated injury, again, focus on that specific injury. But like we talked about, with these kinds of injuries, a lot of times they'll be distracting injuries, probably the most distracting injury. So double check and make sure that there's nothing else going on. Again, same thing with vital signs. Reassess, double check, be prepared for any kind of shock. Oxygen, control bleeding if you can, treat for shock, put them in a position of comfort, transport them. And again, good communication, good documentation. This one is especially important for documentation. Like we said, this is, if you didn't document it, it didn't happen. Or paint a picture for them. Not only because you want to give this patient the best care they can get, you also want to protect yourself from any legal issues. Okay? Unfortunately, that's kind of a world we live in. So be prepared that you need to document extremely well what exactly you touched, what exactly you assessed, and what you did. And injuries may not always be obvious, like we said. Just be prepared for any signs of shock, and if they have blood in the urine, that's a good indicator. There's some things you need to think about for bladder injury. Again, these injuries are going to require more advanced care than what we can provide, so they always need to be transported as quickly as possible. For the males, make them comfortable. Steroid dressings to cover the areas of stripped skin. Apply direct pressure to control bleeding. If they've got something stuck in it, don't move it. If they've got pieces of it that aren't on their body anymore, try and bring them with them. You might be able to put them back on. Then again, if the whole thing is completely sliced off, we're going to have to worry about blood loss. If it's, for lack of a better word, broken, it's damaged, if it's angled, bent wrong, there's going to be a lot of pain, a lot of bleeding, and a lot of fear, okay? Most of us like this piece of equipment. When it looks wrong like that, we're going to be terrified. So try and maintain some professionalism and talk to them nice. A lot of these injuries, it's a vascular system, so just be prepared for bleeding. If a small piece of the item is stuck in a zipper, you can try and unzip it. But if it's a large piece, go ahead and cut the zipper out of the pants. Don't try and unzip the whole thing. Just tear more up. So urethral injuries aren't uncommon. Just be aware. It's a good idea to find out if they can urinate and if they do have blood in the urine. And that bottom part goes back to where we're talking about stuff stuck inside it. We're not going to mess with it. That's going to take surgery. So for the bottom part of this tool, it can get avulsed. It could damage the scrotal contents. If we can, we're going to put moist sterile dressings on it. Wrap them up if we have to. Blunt trauma to them can cause rupture. Rupture with these will accumulate blood. You'll have that swelling, that hematoma. If we can, put ice on it. All right. The female side of things, we've got our lacerations, avulsions. We're going to put moist sterile packing on it. Put a little bit of pressure, but we're not going to pack it. We're not going to shove anything in there. Okay. Same thing, if there's any foreign bodies in there, we're going to leave them there. We're not going to mess with it. We're going to stabilize it if we can. Same thing as guys, injuries are painful, not necessarily life-threatening. That being said, females, everything's pretty much on the inside. They're going to have to be evaluated in the hospital. Okay. Specialized equipment, tools to see in there to see if anything else was damaged. Rectal bleeding can be caused obviously by sexual assault, putting stuff in there that doesn't belong, hemorrhoids, ulcers, you name it. Unfortunately, that is common, sexual assault and rape. Like we said, if they have clothing, try and keep it in pristine condition. Don't touch it, don't mess with it too much. That way they can collect it for evidence. They may not have a lot of life-threatening injuries, but this is a life-altering thing that just happened to them. Like it says, we may only be able to talk to them and try and comfort them. They may be beyond that. We're not going to not take care of them, but we need to be aware of their mental state as well. At the same time, they may have other injuries. Besides that, they could have abdominal trauma, they could have chest trauma or head trauma, stuff we need to be prepared for. Again, if we don't have to, don't mess with it, unless there's obviously some bleeding that we need to take care of. Document, 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 like I talked about. Okay. If we can, keep them from washing, keep them from doing anything to lose or compromise any evidence. At the same time, we still need to treat these patients' injuries. Okay? Just do the best you can. Right. So peritonitis, inflammation in the abdominal cavity would most likely result following an injury to what?
E.
A.
We got a B, we got an A.
Hey,
Think about your hollow organs and your solid organs. Peritonitis is that inflammation and
D.
now that you say that, I'm going to go with D.
D.
all right, there you go.
D.
Solid organs bleed a lot, but the hollow organs are going to spill their contents in the abdominal cavity. Okay. So out of those, the stomach's the only one that's hollow. Okay, because it's got that container for all our stomach acid. All right. So if that spills out, we're going to have a lot of problems with inflammation, sepsis, So which of the following organs would be most likely to bleed profusely if severely injured?
A.
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 Nil.
A.
So just like the previous
A.
one talking about hollow, this one's talking about solid organs. Biggest solid organ we have down there is the liver. So notice it says 40% of the total blood volume at any given time. That's a lot. So definitely that one's going to be your main concern. All right. So the following statements regarding intra-abdominal bleeding is false.
D.
C.
A.
C.
B.
I'm gonna say C.
All right. Yeah. So sometimes we may not have that pain and tenderness necessarily, depending on where that injury was. The cavity's kind of big. It may take a minute to truly get painful or to have that tenderness. Because like it said a little bit further back in the PowerPoint, the solid organs can move instead of just leaking. So it may take just a little bit. All right. So when seatbelts worn properly, airbags deploy, injury may occur to what? Think about where your seatbelt.
A.
B.
I'm gonna say C.
C.
Yeah. So it sits right over those crests on the pelvis. So if we have that rapid deceleration, that thing gets tight. We may have it, even if we're wearing it correctly. So inspecting the interior of a wrecked automobile, you should be most suspicious that the driver experienced abdominal injury if you find what?
A.
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 Yeah. Yeah, if we see that student was kind of crushed, we're definitely going to start thinking significant trauma. So other than applying moist sterile dressing covered with a dry dressing for treating abdominal evisceration, alternative form of management may include what?
D.
D.
Yeah, deal. So remember, these are all sitting inside our abdominal cavity in a warm, humid environment. If we can't put that moist sterile dressing on it, we need to at least put something covering it completely. Transport the patient with possible peritonitis following trauma to the abdomen. Which position will he most likely assume?
B.
Yeah,
B.
B. So that's that kind of guarding we were talking about. Okay, trying to take some ease off those muscles. A 16-year-old boy was playing football, struck the left flank. Vital signs are stable. Or he's in severe pain. What kind of injury should we expect?
C.
B.
C.
C.
B and C. Well, which one is it going to be? We see. So,
Flank is more the side.
Mike is on the side, closer to the back. That's, you think on your kidneys. If it's more towards the front, that's when you'll think the spleen. Hematuria. What do you think that means?
B.
B.
B. Blood in the urine.
Right, because hema was blood, and urea is urine, right? So that dark tarry stool stuff is melena, and then the bright red blood in the poop is hematochezia. And then we talked earlier about hematemesis. Right, so when caring for a female with trauma to the external genitalia, the EMT should
D.
D.
A.
D. D.
A.
C.
as long as none of y'all pick B, okay? All right. Remember, if it's the external part, we can put a little bit of pressure on there. Just as long as we're not putting anything inside of it. At the same time, moist, sterile dressings, for one, could deal with infection. It could also wash off any evidence if that's something we're dealing with. So just need to put some dry dressing on it, put a little bit of pressure. All right. Look, we made it through that chapter 2. Just did this one. Chapter. Let me go ahead and get started. Everybody's still here, so that's good. All right, orthopedic injuries. Most of the time, this is what we see patients for more often than anything else. Yeah, most of the time, they're obvious. Thankfully, our bones, when they break, kind of stick out. Depending on how bad it is and what part of the body it is, you may have that short-term or long-term disability, where you're either in a sling or you're in crutches or you're bedbound. So those skeletal muscles attached to the bones usually crosses at least one joint. So remember, those are voluntary muscles because you actually have to have that brain signal saying, okay, I'm going to move my arm. So those voluntary muscles move the arm. That makes up the largest portion of our muscle mass. Right. So just like everything else, skeletal muscles supply with arteries, veins, nerves. And it's attached directly to the bone by tendons. Our skeleton, as we know, gives us our form. Protects our vital organs, allows us to move. Marrow produces blood cells. And we've got 206 of them. There's your skeleton right there. We've got our brain case Skull protects the realistically most important part of the body. Thoracic cage protects our heart, lungs, great vessels. Talked about that a little bit earlier. Pectoral girdle, that's your scapula and clavicles, some shoulder blades, collarbones, right there. Just a little bit of A&P to get started with the chapter. So your upper extremities from your shoulder to your fingertips. So you've got your humerus, which is the large bone, and your radius and your ulna. And your hands got the three different sets of bones. You got your carpals, metacarpals, and your phalanges. So your pelvis supports the body weight. Your lower extremity has thigh, leg, and foot. You got your femur, biggest bone, body, tibia, fibula, and that patella in your knee, your kneecap. Then your foot has those three classes of bones. These ones are called your tarsals. So you got your tarsals and your metatarsals, and then your phalanges. This gives us the framework for the muscles and tendons to be attached. Joints are where two bones come into contact. You got that fibrous capsule holding them together, lubricated by synovial fluid. That kind of lets us kind of glide and move those bones without scraping them up and grinding them down. And that's what allows us to move. Sometimes that fluid can get in, you can have an infection from that. You'll get inflamed. You'll have sometimes kids will suffer from that. Every once in a while, and they'll have what's called transient synovitis. They'll have a little bit of pain in their hips, and that's from that fluid getting infected and inflamed. Just a little tidbit that we used to deal with that with our twins when they were little. Most of the time, to break these bones or dislocate them, you have to have a significant amount of force. Again, that comes from multiple different places. You can have direct blows, indirect forces, such as, you have your car crashes, so the initial impact doesn't do it, but then the force of you hitting something else. Twisting forces, and high energy. High energy could be, again, car wrecks. Could also be high-powered rifles, breaking those bones. So fractures, again, by definition, it's a break in the continuity of the bone. It's either closed or open. Just like everything else, it's either on the inside of the skin or it breaks through the skin. It can also be described as non-displaced or displaced. So a non-displaced one, nothing out of the ordinary. It doesn't look odd. It just has a fracture and it has a break. If it's displaced, that's when you'll see that deformity. You'll have, shortening, rotation of that leg, or something will be bent the wrong way. So there's a couple different fractures. Probably good information to have. Just remember, green stick fractures are mostly affected with kids. It's usually fairly hard to fracture a kid's bone because it's still growing, it's still pliable. Yeah, that top leg kind of looks busted. That's definitely a deformity, right? So that'd be displaced. So always suspect a fracture. Yeah, a little bit. So if they got deformity, tenderness, obvious guarding, swelling, any of those are present, good idea to consider if it's fractured. The one on the bottom there is a little bit harder to tell, but you can tell that his knee on the left side is swelled up. signs of fractures again: bruising, crepitus, false motion, exposed fragments. That'd be a pretty good indicator. Pain, locked joint. They can't move it. So dislocations or the disruption of the joint. Sometimes it'll go back to normal on its own. But if it doesn't, it's definitely a problem. So if it does dislocate, kind of same thing as with fracture injuries. You got your deformities, your swelling, pain that's increased by trying to move it. It's tender. They may not have that joint motion, and then they may have numbness, tingling, or a loss of circulation in that arm or leg. Sprains are, I'm sure we've all had sprains at some point in our life. That joint gets kind of twisted or stretched. It could be mild, it could be severe, it could be almost as bad as a fracture. Ankles, knees, shoulders, all of our parts that hinge on other working pieces are more vulnerable. Signs and symptoms, again, could be quite a bit of the same. You got bruising, could have swelling, tenderness, difficulty moving. Can you think it's a sprain and end up being a break? Sure. Can you think it's a fracture or dislocated and it be just a simple sprain? Yeah. So just always err on the side of caution. Treatment's a lot of the same. You stabilize the injury. So strains, that stretching or tearing of that muscle. Again, same thing as the other ones: pain, swelling, bruising to those tissues. Probably will not have any deformities to it besides that swelling. Amputations, obviously, same thing we've been talking about. A piece gets cut off. It can have the potential to damage the skeletal system, depending on how and where that amputation was. So right there, he'd probably sliced off some of the bone to that piece. Same time, these can lead to major changes or illnesses. For one, once that bone's injured, it's more likely to have another injury. Same time, it may not come back as strong before. You could also have some kind of inflammation from it. You can have infection. So just be aware of that kind of effect these injuries can have. Same time, it changes somebody's mentality. Somebody that was fairly athletic, go-getter, hiking all the time, could fall down the mountain, break two of their legs, and after that, they never do anything but sit at a desk again. So just be aware of some of those kinds of things that can happen. Again, open fractures, same thing as open injuries. We want to try and prevent any further contamination. We're going to try and prevent further injury. Obviously, reduce the risk of infection. We're going to hopefully minimize pain with either cold packs, ice, or analgesia. We remember what analgesia is way back from our medical terms. Does anybody remember what that one means?
Isn't it blood clotting?
Let's take a look at the sentence. So minimizing pain with cold and analgesia. So all that fancy word means is just pain medication. So most time we're gonna, especially if this person's got a significant break, we're gonna try and give them some form of pain medication.
Amen.
Yeah. They'll be getting the feel good juice. And then we need to make sure they're taken to the appropriate facility. Good thing is with Tyler, both hospitals up here can take care of orthopedic injuries. Some of these outlying facilities only have orthopedics on certain days. So if you're out and about in some of these other places, just be aware and keep that in the back of your mind when you're getting ready to transport. All right, golden hour. I haven't talked about the golden hour much, but the golden hour is the time frame from the moment of injury to getting treated at the hospital. A lot of times it's associated with heart attacks, any kind of medical issues. At the same time, it's critical for that limb viability. If it's amputated, if it's got a fracture, if it's dislocated, the longer it stays hypoperfused without oxygen, the more significant that damage is going to be. The good thing is most of these injuries that we're talking about right now are not critical. Going back to seeing size up, like everything else, pretty much the same. Good thing is most time with orthopedic injuries, they'll end up being isolated. Circulation, always good to find out if they've got a pulse in the affected limb first. Sometimes I even have a hard time feeling for a pulse on a foot every once in a while. You can also check for capillary refill. Push down on their skin. If it takes more than 3 seconds for the color to return to normal, probably a circulation issue. Same time, if it's cold, getting cool, probably not a good sign. All right, it's a transport decision like we talked about. If they've got an obvious airway breathing problem or life-threatening bleeding, rapid transport. We can stay in play if the mechanism of injury and their signs and symptoms and assessment shows that we have a little bit more time to dig deeper into their injury. Again, we can get a good history that helps us with treating the patients. Again, pertinent negatives is great, especially when you talk about orthopedic injuries. I see you have a broken leg. Did you fall? No, I didn't fall. Something hit me in the leg and I sat down. Or I fell and landed on my arm. Well, did you hit your head? Do you have any neck pain? No, I don't have any neck pain. Pertinent negative. That way we don't have to put a neck collar on. Physical exams, it's a secondary assessment. We're going to be getting a little bit deeper into it. If you have significant trauma, if you have a major car wreck, blast injuries, anything that has multiple possible injuries, you're going to do a secondary assessment for the entire body. Okay? Start at the head, work down to the feet. Anytime you have some kind of lacerations, always suspect an open fracture first until proven otherwise. Same time, any deformity of that bone, you need to start thinking if they have any blood vessel injury to it or if they have any nerve compromise. Assess their mental status. Use the 6 P's for assessment. Obtain baseline vitals. Y'all remember do you remember going over and looking through the book and finding the 6 P's for assessment?
I don't. So I was about to ask what they were. If you have them on the top of your head.
You have your pain, paralysis, paresthesia, which that's your numbness or tingling, pulselessness, pallor, which is your skin color where it gets pale, and then pressure. Those are your 6 P's. Again, reassessment. If they only have one isolated injury and their vitals are stable the first time, probably assess in 15 minutes. If it's something really significant and they look like they're going into shock, you're going to do every 5. So again, if they don't have any life threats immediately, then you can kind of sit there and stay and play, and you can stabilize them on scene. And again, document the entire thing. Paint a good picture, not just for legal reasons, but for patient care. That way the doctors that see this care report will know what was going on, especially with orthopedic injuries, because they may be seen at the ER and then they'll be seen by an orthopedic surgeon. Well, that orthopedic surgeon may get a portion of the report that you gave, but they'll get that patient care report and they'll be able to see, okay, well, this is what the field crew saw. This is how the patient presented. This is what that injury looked like at first from this specific mechanism of injury. That way they get to see the big picture. So again, start with that primary assessment, which starts with our scene size up, the general impression. Make sure our ABCs are intact. Finish our primary assessment, do the secondary assessment for the entire body if they've got multiple injuries, or if they've only got the one, you can focus on that one. Just be aware of any possible internal bleeding. So splinting, that's where we take any kind of flexible rigid device and use it to maintain the position of whatever extremity was injured. Ideally, we're going to splint all fractures, dislocations, and sprains before moving the patient, unless they are in obvious danger. Most times, splinting reduces the pain and makes it easier to move that patient. Keeps us from causing any further damage to multiple different parts of the body associated with that injury. Helps with kind of reducing that blood flow to that injury in case there was any bleeding. Keeps it from moving, which would cause increased pain. Hopefully reduces any chance of paralysis. It keeps any further injuries from happening, especially if it's an open wound. Good tips to live by. You can obviously remove clothing from that area. Can't very well splint something we can't see. Always record their neurovascular status. Double check if they've got a pulse. Double check if they can move that limb. Double check if they can feel you touching that limb. Check their cap refill. And then when you splint them up, do it again. And then when you move them, do it again. Do it anytime anything changes with that patient. That way you can keep track of if they lose any of those sensations. Cover your open wounds like we've been talking about this whole time. And then ideally, we're not going to move these folks until we can splint those injuries unless there's clear and present danger. If we've got rigid splints, we want to make sure we get some padding on there. Same thing we learned from backboards. We put people on backboards, it actually hurts them more than it helps. Make sure we pad these things. They do get uncomfortable. Maintain that manual stabilization. Just because we're putting a splint on doesn't mean we don't need somebody to hold that arm in place until we're done. So when we're trying to put the limb back in its in the correct position, or if we're trying to take care of it and we have any kind of resistance, don't force it. Just splint it the best you can with the position it's in and leave it alone. If we think they might have a possible spinal injury in addition to the other fractures they may have, we want to try and keep them in that neutral position. That way we're not injuring their spinal cord or anything. And like it says, when in doubt, try and splint it. Again, rigid splints, they're made from firm material. Pretty much be applied on any side of the injury, and it keeps it from moving. So those two little tidbits. If the deformity is too severe, we're going to splint it the way it looks. Or when you're trying to get traction on it and it starts really hurting, or you're having to actively fight that injury, just leave it be, splint it the way it is. So formable splints, these are like those orange rolls we have in the truck. Same time, there's some that can be inflated, air splints, things like that. They're comfortable, they do good support. They also give great pressure for bleeding injuries. Downside is they're good for pretty much anything below the elbow or the knee. Not much else. Zippers can get stuck. Again, with air splints, you also have to think about the pressure. Okay? Any kind of pressure, ambient pressure effects on the environment can also affect the pressure that's of the air in that splint. Traction splints. So, traction is obviously pulling the body piece in the direction of its normal alignment. Most of the time, you're going to do this for femur fractures. If you've seen a femur fracture, if you've seen an open one, you can guarantee that they are some of the most painful things you will ever see. Femur is the biggest bone we've got. If that thing snaps, for one, we've got a lot of risk that we could slice through from our arteries. We just have to be careful with that. Traction splints and providing traction for this, you would be surprised how much pain relief you get just from putting it back into place. That's what the main goal is. It's going to stabilize those fragments, keep them from slicing anything else, rubbing on each other. Not going to use traction splints for pretty much anything else. It's very, very specific. So there's kind of a little diagram where the leg should be and how you need to pull the traction for it. Pelvic binders. Pelvic binders are great. They will stabilize a unstable pelvis pretty good. Will also help reduce bleeding from those injuries. It's not a complete fix, but it will be a temporary one until you can get them to the hospital and they can get surgery. Most of the time, pelvic binders will not be available. You can also use sheets. Those blue sheets on the cot, on the stretchers in the truck, they do work. So, downsides to if you splint wrong, obvious compression of nerves, tissues, and blood vessels, you could further damage it. If you're splinting when they have a life-threatening injury, you're delaying patient care in the first place. Circulation is going to be impaired. You're going to make the injury worse. And then you could create new injuries just from trying to splint that thing. So only do so if you're confident in your skills. And most of the time with orthopedic injuries, especially limbs, we don't have to go fast. We don't have to go super quick. Now, if they've got a pulseless limb, if they're losing circulation, yes, that's a significant priority. That kind of changes the mentality a little bit. Most time we don't want to be too excessive. That's something on the bottom to consider. Is if you're fairly far away, especially if you don't have circulation going to that injury, kind of want to get them there a whole lot quicker. Those load and goes versus stay in play. Clavicle and scapular injuries. Collarbone injuries are fairly common. Most time, you'll know it because they'll be holding their arm in front of their body. Okay? They'll already have it in a position of comfort. You can sling it up just like that. Shoulder blades are a little bit more rare, I guess would be a good word for it. Most time, it's got to have some kind of blow to the back. And like those pictures show, most time, that'll take care of it right there. Humeral head most commonly dislocates anteriorly. Shoulder dislocations are extremely painful. The downside is we can't really stabilize them very well. Because once we bring that arm towards the chest, it's going to pull on it and it's going to cause pain. Just whatever the patient says is the most comfortable, that's the way you're going to splint it. You can try applying traction for a humerus. It will not be with the traction splint, but if you can't, splint it in the position it's found. Remember, distal means further away from the body, so that lower end of the humerus, those fractures are more common in kids. Right there. Not very comfortable. So if they cannot extend the elbow, it's a pretty good indication of the injury. Fracture of the radial head, that's when we catch ourselves with our arm. Anytime you try to rotate that elbow or wrist, it's going to cause some kind of pain. Again, just like everything else, they could be serious. We just need to be careful and take care of them the correct way. And reassess, keep an eye on their pulse, motor, sensory, cap refill. And if they do have decreased circulation or loss of sensation, get them to the hospital fairly quick. And same thing with fractures, pretty much the same thing of the forearm. Rigid boards, padded boards, vacuum splints. You can use pillows if you have them. Same thing with wrist and hands. If anything's taken away from this, just make sure you splint correctly. Okay? If you can't splint it in the correct position, splint it the way you found it. Pelvis fractures, it usually takes quite a bit of force to break the pelvis. A lot of times you'll have quite a bit of blood loss on the inside. Every major fracture in the pelvis could have the potential of bleeding up to 500 cc's of blood for each large fracture. So really, if you break that sucker 3 times, that's a third of your blood volume right there. So anytime somebody complains of lower back pain, lower abdominal pain, keep that in the back of your mind. So a lot of times to check stability, we're going to push in, kind of push down a little bit, see if it's stable. Obviously, if they start yelling at you, you stop. Dislocation will only occur after significant injury. Obviously, we're not going to try and reduce this thing in the field. Okay, this is going to take a little bit more higher level care than we have. Main thing for treatment wise, keep them stable, monitor their blood pressure, treat pain, keep them comfortable. So, proximal femur fracture, pretty significant display. They'll have that leg rotated outward. Most of the time, that limb is going to be shorter than the other one. Double check if they've still got pulse and motor and sensory to it. Splint it to the other leg if you need to, in the position it's in, and transport them. So once you get kind of down towards the shaft of the femur, you'll notice that if they do suffer this kind of fracture, their thigh muscles will kind of spasm. They're trying to keep that break stable. Same time, it could be open. Like we said earlier, there's a lot of vessels there, a lot of arteries. You could have significant blood loss if it's an open fracture. Again, if you have an open wound, we're going to obviously cover it. These ones are the ones we use traction splints on. A couple different knee injuries. We've got your ligament injuries, your dislocated patella, and the fracture of the bony parts. Okay. So once you dislocate that knee, it could cause compromise to the entire limb. Okay, that ligament can get damaged, it can get torn. Now, if you got a good distal pulse, splint the knee, take off. Okay, get them up to the orthopedic specialist. And like it says, if we don't have any significant deformity, if they've got a good distal pulse, we're going to splint and go. If they got a significant deformity like we've been talking about, you're going to put it in the position it's found. If you don't have a pulse, contact medical control, see what they want you to do. Most of the time, it's going to be get them to the hospital. Okay, there's probably going to be very few medical controls that are going to willingly let you try and produce that thing, especially if we don't know what we're dealing with or what we're doing. So there's the dislocation of that knee. Obviously looks pretty painful. Splint it how you find it. Don't push on it, don't mess with it, just leave it alone. Tib-fib fractures, it can be at any point between the knee and the ankle. Okay. Most of the time, if you've got one, you've got the other fracture. Try and use a long leg splint if you got them, or an air splint. If not, use what you got. Form it to it, make it rigid. I'm sure everybody's rolled their ankle before. Most of the time, they quite a bit of pain, swelling, tenderness, makes it difficult to walk. They always need to get looked at just to make sure there's nothing limb altering going on. And any open wounds you find, obviously we're going to treat those and dress those. Again, hammer at home, check PMS, pulse motor sensory. If you have any kind of major deformities that can be treated with traction, make sure you do so safely. But once you get it in that position, you need to make sure it's splinted. Okay, we don't just pull the traction and say, okay, we're good, and then let go. foot injuries. Again, we've got multiple bone sets down there. We can have dislocations or fractures of any number of all three of those. At the same time, anything that, especially looking at this picture with the kid jumping down, that energy is going to be transmitted up from the feet all the way up the spine, so you could have further injury upwards. So double check if you have some kind of dislocation. I'll always check PMS. Ideally, personal preference, of course, pillow splints are real good for this. Always leave the toes exposed. That way, for one, you can assess PMS. Okay, you can check their cap refill. You can see if they can wiggle their toes. They can also see if they can feel you touching them. Again, general treatment. That rices. It's back there again. Most important thing is that splinting part. Amputations. As long as it doesn't look like a bunch of hamburger meat, they can usually get pretty lucky and reattach the parts. Make sure you put some bulky compression dressings on it. Obviously, if it's hanging on by a thread, we're still not going to just pop that piece off. Okay? Realistically, if you cannot control the bleeding with direct pressure, go ahead and move to the tourniquet. Don't waste a whole lot of time. If it's completely cut off, take that piece that's not attached anymore, get it in a sterile dressing, place it in a plastic bag, hopefully get it in some ice. We don't want to put it directly on ice, but we want to try and keep it cool enough that it's still a viable piece. Again, compartment syndrome, we talked about this earlier. We got a fractured tibia or forearm with kids. It does happen 6 to 12 hours later. These are the kind of folks we're going to need to keep an eye on. Ideally, they should have been transported when the initial injury happened, but we need to get them there quick, and we also need to notify the hospital of these kind of issues. All right, let's go ahead and review this thing. Skeletal muscle is referred to as what?
A.
Hey,
Got 2A.
Good choice.
B is that striated muscle. Sure, it's got that kind of striped characteristic to it, and it's going to attach to the bones. Smooth muscle, think of smooth muscle as like your blood vessels, your heart muscles, your lung, stuff like that. All right. Your spine to soccer game for 16-year-old male. You deliver him to the hospital. The physician brain. What is
C.
C.
yeah. Kind of stretch those ligaments out. More toward them. Young male has musculoskeletal injury and is unresponsive. You will not be able to assess what?
D.
D.
So remember, we're trying to assess motor and sensory. Can you move your feet? Can you feel me? Most time, if they're unconscious, we're not going to be able to get that kind of answer. Just be. So we can still check pulses, even if we're not sure. We can check cap on them. Right. Purpose of splitting a fracture is what?
B.
B.
Yeah, we don't want to move those parts anymore. They already are. We don't want to.
C.
Injuries to the blood vessels. We don't want to cut off any nerve endings. Trying to keep that, limit the damage as much as possible. Motorcyclist crashed his bike and has closed deformities to both of his mid-shaft femurs. He's conscious and restless. His skin's cool and clammy. He's got radial pulses. The most appropriate splinting technique for this patient involves what?
B.
B.
I'm going to go with B as well.
There you go. So let me see. So the downside.
C.
So traction splints are good. Okay, if this was one femur fracture, then we do a traction splint. The downside is if he's got both, it takes a little bit more time. Ideally, what we can do is we can splint him to a backboard and get him to the hospital. So while it's a good answer, it just wasn't the answer they're looking for. So effectively immobilize a fractured clavicle, you should apply what?
A.
A.
Yeah.
Yeah. Like we said, most of the time they'll already be holding that arm in that position. All we got to do is just make sure we stabilize it. Patient tripped, fell, and landed on her elbow. She's in severe pain and has obvious deformity. You should do what?
A.
A.
Say B.
So ideally, we want to stabilize it first. That's not saying put it in the correct position or anything like that. We're just holding it where it is at that time. Then we're able to check the pulse, motor functions, everything like that. Kind of think of it the same way we do C-spine. Usually when we take C-spine, we do C-spine before we start trying to check and manipulate and look to see if there's any injuries. All right, you got an open extremity fracture. You do what?
D.
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 Remember, we want to cover these open wounds. So at the same time, if we've depending on where, I see where we get the injury from because we're thinking air splints, right? Because during the presentation it says air splints are good at compressing that blood. But we just want to make sure we, for the sake of a test, if the question is on there, we're going to cover up the open wounds first. Sometimes, because if it's a humerus fracture or a femur fracture, we may not be able to use the air splint. We may have to cover that injury anyway. Does that make sense?
Yes.
Yes.
Yeah. So when it's a lower injury and we're able to use the air splints, if we have them, yeah, that'll cover up the injury. But for anything else, we need to make sure that we're always, for sure, every time addressing the wound with that splint on it. All right. So which of the following musculoskeletal injuries has the greatest risk for shock due to blood loss?
A.
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 Yeah, we were talking about that there. Like we said, any kind of fracture, you can lose up to 500. Right there, it shows bilateral femur fractures can also cause severe blood loss. Yeah. All right. Patient injury. They injured her knee while riding a bicycle, lying on the ground. She's got her left leg flexed. It's in severe pain. She can't move it. Her assessment reveals obvious deformity to her left knee. Distal pulses are present. Most appropriate treatment for injury involves what?
B.
B.
A.
A.
B.
DNAs?
B.
Yeah. We're just going to keep it the way it's found, especially if it's a knee injury. Okay. We know we've got good pulses. They're strong. We don't want to compromise that. So we'll just kind of keep it the way it is, splint it as best we can, stabilize it, and get them to the hospital. Look at that. We survived. All right. Let me go ahead and finish this recording.